Okay, let's unpack this. I mean, we live in an age of just incredible medical technology.
Absolutely.
We can thread cameras to the human body, use robotics, perform these minor miracles every single day. But that whole high-tech world, it really rests on some very low-tech foundations.
And if those foundations fail, the consequences can be catastrophic.
Exactly. We are talking about the hidden, pervasive risk inside our healthcare systems.
Yep.
Infection. Specifically, we're doing a deep dive into infection control, aseptic technique, and really focusing on preventing nosocomial infections.
Right. Those are the diseases you acquire right there inside the hospital or clinic. It's the ultimate paradox. You go in to get better, but you're exposed to these risks that just require constant vigilance.
And for this deep dive, we're really zoning in on the endoscopy unit.
Yes, because the procedures are so invasive. The stakes for both the patients and, the staff guiding them are just extremely high. The sources we looked at really highlight the specific ways that pathogens.
The organisms that cause disease?
Exactly. The pathogens exploit both the most complex and sometimes the most mundane procedural failures.
So we can skip the textbook definitions and just jump straight onto the battlefield. What are the major bacterial threats that are exploiting these lapses in procedure right now?
Well, we have to start with the ones transmitted by contact. These often require intense and immediate environmental cleaning. We're talking about Clostridium difficile,
Hey, Diff?
C. diff, yeah, and vancomycin-resistant enterococcus, or VRE.
And these are just nasty, resilient organisms, right?
Yay. They are, and they spread because a failure in the most basic step lets them travel from one patient to the next so easily.
And the sources really zero in on that one crucial, often overlooked detail about that most basic step, which is hand hygiene.
Precisely. And this is where it gets absolutely essential for anyone working in or even just visiting a healthcare environment. If we're dealing with a spore-forming organism like C. diff, that quick squirt of hand sanitizer we all rely on,
It doesn't work.
it just won't cut it. The sources make this rule mandatory.
Yeah.
You have to take 20 full seconds to wash your hands properly with soap and running water.
20 seconds. I mean, that feels like an eternity when you're busy
Yeah.
running between tasks. But the difference is mechanical, isn't it? Why does sanitizer fail against C. diff?
It's all about the biological structure. So most bacteria we worry about are in what's called their vegetative state. They're actively growing. They're vulnerable.
Okay.
C. diff, when it's under stress, forms this hard protective spore. And that spore is chemically resistant to alcohol-based sanitizers.
So you can't just kill it with alcohol.
You can't. You need the physical friction, the mechanical action of scrubbing, combined with soap, to literally strip those spores off your hands and wash them down the drain.
So that's a failure of the human factor.
Oh.
Now let's talk about a failure of design, of engineering. Because one of the most severe hospital-acquired infections is carbapenem-resistant enterobacteriaceae, CRE, a superbug that has, tragically, been linked directly to high-tech equipment complexity.
And what's fascinating here is that we can trace these infections, which were often fatal and led to massive regulatory alarms. We can trace them directly back to a specific feature on certain endoscopes.
Which ones?
Specifically, the specialized scopes used for ERCP and EUS procedures. These scopes have a part called the elevator.
The elevator. It sounds like something that should just, lift a small tool.
Yeah.
How does that become a death trap?
It's structurally complex. Imagine a tiny hinge and a recess that you just cannot fully access with standard brushes, or even with the flow of disinfectant. It was a perfect microscopic harbor for bacteria like CRE to survive the entire sterilization process.
So this tiny mechanical component completely undermined the whole reprocessing protocol. Did the FDA have to step in?
They did. This was a critical public health crisis where the equipment itself was the vector. The FDA asked manufacturers to innovate to fix it.
And what was the fix?
Well, that innovation has led to some expensive but necessary solutions. Things like new designs with disposable tips that cover the elevator, or in some cases, moving toward fully disposable endoscopes.
Wow.
It forced the entire industry, from engineers to purchasing managers, to rethink what they're willing to risk for a durable device.
It's the ultimate caution for engineering, I guess. Every detail matters, even a tiny recessed hinge. But the sources show that reprocessing failures aren't always so complex. Sometimes they're astonishingly low-tech.
Oh, indeed. We see multi-drug-resistant Pseudomonas aeruginosa spreading when there's a general reprocessing failure or, and this is truly shocking, when water bottles used during the procedure aren't properly sterilized.
They're kidding.
Or even worse, when technicians just top off the bottles day after day, creating this beautiful aquatic breeding ground for Pseudomonas.
That is the stuff of nightmares, a life-saving procedure undone by a dirty water bottle.
And we also see Helicobacter pylori, which is known for causing stomach issues, transmitted when either the scope isn't processed correctly or when reusable biopsy forceps aren't meticulously disinfected.
So if we zoom out, preventing any of these requires a completely unbroken chain of proper steps.
An unbroken chain: pre-cleaning, manual cleaning, high-level disinfection, proper drying, and secure storage. If you skip that manual cleaning stage, the next stage, the disinfection, it just won't be effective.
Okay, so if mechanical or procedural failure is the key for bacteria, are the viral threats driven by different kinds of failures? Let's move on to viruses like hepatitis B, HIV, and hepatitis C.
The landscape has definitely changed for some of them. Hepatitis B is much less of a concern now, thanks to universal vaccination requirements.
So everyone should be immune.
Pretty much, and HIV is generally cleared by standard scope processing. Scope-related transmission of HIV has thankfully not been reported in the literature we reviewed.
Which directs our attention straight to hepatitis C or HCV. What are the primary risk factors for HCV transmission in this setting?
HCV risk factors include, the classic needle stick injury or, yes, improper scope reprocessing. But there is one procedural failure that led to one of the most egregious outbreaks in recent history:
And what was that?
the misuse of multi-use vials.
Tell us about the propofol outbreak.
Yeah.
This is where a procedural failure just became a total disaster.
It's a perfect illustration of how routine shortcuts can create massive systemic risk. So, in Las Vegas, Nevada, they were using multi-use vials of propofol, a very common sedative.
Right.
The team used the same syringe to draw the medication for multiple patients.
Oh, no.
Yeah, think about that process. The syringe is used on patient A, it potentially becomes contaminated with their blood, and is then reinserted into that propofol vial to draw more medication for patient B.
So the syringe contaminated the vial, and that vial then became a source of infection for who knows how many patients after that.
Exactly. It completely breached the sterile barrier of the medication supply. It just highlights that the risk isn't only the equipment itself, but the entire chain of supply and administration.
That is a sobering story. Okay, now we have to hit the final, most challenging category of infectious agents, the ones that require entirely different protocols. Prions.
Prions are unique. They aren't bacteria or viruses. They're defined as misfolded proteinaceous infectious particles.
Misfolded proteins.
Yes, and their core defense against us is that they are frighteningly resistant to standard heat and chemical disinfectants.
And the disease we're worried about here is variant Creutzfeldt-Jakob disease, VCJD, the fatal neurological disease linked to consuming contaminated beef.
That's the one.
So given that resistance, what does the protocol demand when standard sterilization is basically useless?
Well, this raises a profound operational and, frankly, ethical challenge given how valuable these endoscopes are. If a patient is known to have VCJD, endoscopy should be avoided if at all possible.
But if it has to be done?
If a procedure absolutely must be done, the protocol is extreme. That specific scope must be either dedicated solely for use on that very rare patient population, or it must be retired immediately after that single use.
Retired? You mean they take a piece of million-dollar equipment and just destroy it or lock it away forever?
That's right. It's an astonishing economic decision driven by an extremely rare biological risk.
But it makes sense.
It has to. The decision reflects the gravity of the prion risk. Failing to eliminate it would mean risking an irreversible neurological disease in the next patient who uses that scope. It's the ultimate mandate of safety over cost.
Let's shift our focus now to the team, the people performing all this intricate, risky work. Being a healthcare provider, especially in a high-contact environment like endoscopy, carries its own dangers. We saw that so acutely during the COVID pandemic.
Absolutely. The sources really categorize staff risks into three main areas. You have droplet and airborne risks, like the flu and COVID-19.
And the best prevention there.
It seems obvious, but it's essential. Stay home the moment you feel symptomatic.
Then you have the contact risks, like MRSA or C. diff, which we already talked about.
Right. And prevention there relies heavily on proper hand hygiene and rigorous contact precautions, gloves and gowns, all properly used.
And finally, Sharps injuries. That's the one that puts staff at high risk for bloodborne pathogens like HEV, HIV, and HBV if they're not immune.
Exactly.
And the sources mention a very specific procedural precaution here, right in the middle of a procedure involving the biopsy forceps.
Yes. The forceps have a sharp, tiny spike at the end. To prevent the assistant from accidentally stabbing themselves, which is a real risk when you're transferring equipment, the assistant must take the precaution of closing the forceps completely before handing them over.
Such a tiny detail that saves someone from potential lifetime exposure.
It is.
So let's delve into those airborne risks, using the COVID-19 protocols as sort of the high watermark for procedural changes. Endoscopy is a tough environment because the team is usually working so close together right around the patient's airway.
The challenge is aerosol generation. Anytime you're working near the airway, you're creating potential aerosols. So to manage this, protocols became incredibly stringent. The patient wears a mask right up until the moment of sedation.
And the staff.
Staff try to maintain 6 feet of distance where possible, and the number of people in the room is minimized to only those who are absolutely necessary.
And what about mitigating the aerosols generated during the procedure itself?
You avoid standard practices that promote aerosolization, like using a simple nasal cannula. Instead, they might use a special high-filtration mask that vents away from the team, or, in the highest-risk cases, they might even place an endotracheal tube to fully contain the airway.
And all of this is ideally happening in a negative pressure room.
Correct. If the facility has one, that is by far the safest setting. And post-procedure, the patient is masked again immediately upon recovery, and all surfaces are meticulously cleaned with virucidal wipes.
Wow. It's a total systems approach.
It has to be.
And this level of detail makes PPE mastery absolutely crucial. We spend so much time learning how to put on the PPE, the donning, but the sources stress that the real moment of failure is often during taking it off, doffing.
Doffing is where self-contamination happens. You're potentially touching the outside of contaminated gloves or the gown and then touching your own face or scrubs.
That's terrifying.
It is. That's why the sources recommend having an observer actively watch and guide you through the doffing process. It's a critical, high-risk safety step that requires intense training and, mutual vigilance.
Okay, we've covered procedural and technical failures. Let's talk about administrative failure. Or what happens when a known protocol breach potentially exposes a patient? The sources describe this moment as a big deal.
It is a huge deal. The process has to be immediate and transparent. First, the team must inform the hospital infection control team.
Okay.
That team then immediately reaches out to the local public health agency. And for equipment-related failures, the FDA MedWatch system and the equipment manufacturer must be informed at the same time.
But the crucial, and I imagine the hardest part, is the patient notification.
Absolutely. The facility must inform the patient fully, establishing a clear management plan and a follow-up schedule. This isn't just about disclosure. It's about providing the patient with continuous support and monitoring until they are completely free from any serious threat.
The psychological toll on the team must be immense.
It is. They're trained to heal, and having to call a patient and tell them they were potentially harmed by a failure of care is the opposite of that mission. But immediate transparency is the only acceptable route.
And what if a healthcare worker suffers an exposure, like a needle stick? What's their protocol?
It requires immediate reporting. The manager and employee health have to be informed right away. Consultation with an infectious disease expert is mandatory because, depending on the books, especially for HIV or HCV preventive treatment, may need to be started within hours.
And that treatment is tough on the body, I hear.
It can be. So if that treatment begins, compliance and close monitoring for adverse events are critical.
So after this whole deep dive into nosocomial infections, what's the core lesson here for healthcare safety?
I think it's the lesson that complexity breeds simple failure. Every single step matters, and the chain of asepsis is just unforgiving. We've seen that the most sophisticated procedures can be completely undone by a 20-second hand wash that was skipped.
Or a tiny mechanical part like the elevator.
Or a catastrophic lapse in basic sterile technique, like misusing a multi-use vial. Vigilance is the only standard.
It really seems like the difference between a routine, successful procedure and a life-threatening infection often comes down to the most mundane aspects. The true lifesaver in this field isn't the advanced imaging or the high-powered scope.
No, it's not.
It might be the assistant meticulously closing a pair of biopsy forceps, or ensuring a water bottle is sterilized daily, or the regulatory pressure that forced an industry to redesign a tiny recessed hinge.
Mastery of the basics, the mundane, the repetitive. That is the ultimate measure of safety and the true foundation of advanced medicine.
We often focus on these revolutionary medical advances, but you have to consider the incredible depth of training and commitment embedded in these seemingly simple procedures. Where does a lack of vigilance most often compromise the integrity of your own critical routine? Something to mull over until our next deep dive.